Hello and welcome to this webinar on epilepsy syndromes as a roadmap to comorbidities, organized by the Pediatric Commission of the International League Against Epilepsy, the ILAE. My name is Kette Valente. I'm the current chair and a member of the commission, of the Pediatric Commission, as all speakers in this webinar. This webinar addresses key comorbidities associated with DEs, developmental and epileptic encephalopathies, idiopathic generalized epilepsies, especially juvenile myoclonic epilepsy, and focal epilepsies in adults. The relevance of comorbidities or non-seizure symptoms has been emphasized over the years and has become clear that epilepsy is beyond seizures and coexisting conditions are a core components of epilepsy syndromes, sharing some common neural and genetic mechanisms. This is why we believe that this webinar is crucial, is vital for healthcare providers in charge of children, adolescents, and adults living with epilepsy. Professor Stéphane Auvin, Vice Chair of the Pediatric Commission, idealized this webinar. He has always recognized the importance of comorbidities and has been a very active voice advocating for comorbidities in the ILAE. For this reason, Professor Auvin will be co-chairing this webinar with me. Stéphane, please, could you introduce yourself and our first two speakers?
Sure. Thank you. I'm very glad to be here, and I'm very glad that the comorbidity is a topic of the Pediatric Commission today. Then our first speaker will be Dr. Colin Reilly, who is currently working as a psychologist in the UK with youth epilepsy and as a psychologist in Sweden at the Queen Silvia Children's Hospital. His clinical work primarily focuses on psychological and neuropsychological assessment of children with neurological conditions. His research focus is on psychosocial aspects, including behavioral and cognitive comorbidities. He is the current chair of the Pediatric Psychiatric Issues. Dr. Colin Reilly will address autism spectrum disorder in developmental and epileptic encephalopathy, over or underrated. After Colin, we will have Kette Valente, who is pediatric neurologist, pediatric epileptologist, and neurophysiologist. She is full professor in pediatric neurology at the University of São Paulo in São Paulo, Brazil. She is the current chair of the Pediatric Commission, and she is also associate editor in Epilepsy and Behavior. Her research is mainly focused on cognitive and behavioral comorbidity in children and adolescents with epilepsy. Kette Valente will address the spectrum of both cognitive and psychiatric disorder in juvenile myoclonic epilepsy.
Well, now it's my honor to introduce the last two speakers. Our third speaker will be Professor Marco Mula. Professor Mula is a neurologist and psychiatrist, and he's a consultant at St. George's University Hospital, Trust and Foundation Trust, and St. George's University of London. Professor Mula chaired the task force for diagnosis and treatment of psychiatric disorders in the past term that end up with guidelines for the treatment of depression in persons living with epilepsy, adults with epilepsy. He is the current editor-in-chief of Epilepsy and Behavior, and his main focus of interest has been assessment and treatment of coexisting conditions or comorbidities, mainly depression, in adults living with epilepsy. Professor Mula will address the relevance of screening and treatment of depressive symptoms in focal epilepsy. Our last speaker, last but not least, is Professor Stéphane Auvin, co-chairing this session. who is a pediatric neurologist and epileptologist at Robert Debré University Hospital in Paris, France. His research addresses early onset pediatric epilepsies, epilepsy drug development, and the rare epilepsies. Professor Auvin is the past chair of the Pediatric Commission and the deputy editor of Epilepsy or Epilepsy. Professor Auvin will summarize our lectures, creating this roadmap for epilepsy-associated comorbidities, and also will provide a translational approach delving into preclinical studies that can help us to understand this intricate relationship between non-seizure symptoms and epilepsy. Our speakers will address questions at the end of this webinar. I hope you enjoy.
Hi everyone, I'm very glad to have the opportunity to talk about autism and the DEEs and address the question of whether or not autism as a diagnosis is overrated in the DEEs. So here are my disclosures of conflict of interest. So today's presentation, so I'm going to start off talking a little bit about the developmental and epileptic encephalopathies, talk a little bit about autism and epilepsy and autism in the DEEs, giving the example of Dravet syndrome, and also talking a little bit about the potential for variable presentation of autism in the DEEs, and then addressing the question, is autism an important comorbidity in children with DEEs? So is it an overrated diagnosis? But also emphasizing that when children have a DEE, they may have autism and epilepsy, but there's also an increased risk for a range of other neurodevelopmental problems, which are very important to consider. So if we take the DEEs, the term developmental and epileptic encephalopathy was proposed in the 2017 ILAE classification of the epilepsies to denote an epilepsy associated with developmental impairment, which may be due to the underlying etiology or the superimposed epileptic activity, or both. So developmental encephalopathy implies that developmental delays are the direct result of the underlying cause of the epilepsy. And in addition, some children with DEEs also have an epileptic encephalopathy due to the frequent seizures or markedly abnormal EEGs, and this may also substantially worsen developmental outcomes. In most cases of DEEs, epilepsy onset and developmental impairment are seen early in life, and seizures are often very difficult to treat. This figure just sort of provides some visual support to the idea that the developmental impairment in DEEs arises both from the cause of the epilepsy, often genetic etiology, but also the epilepsy or epileptic activity. It's important to state also that the cause of the epilepsy, so for example, genetic etiology, can also contribute to the epilepsy or epileptic activity. And of course, there are many other possible contributory factors to developmental impairment. For example, the use of anti-seizure medications. This may also impact on developmental functioning in the child, and maybe something that needs to be considered when considering how best to optimize outcome in these children. So when we talk about the DEEs, it's important to reference what particular epilepsy syndromes we're talking about. This table here comes from Elaine Worrell's publication and colleagues in 2022, and the first list there, starting with early infantile DEE, Those conditions or epilepsy syndromes are predominantly present in the first year of life, so quite early on. And then we move on to the second group, for example, epilepsy with myoclonic atonic seizures, Lennox-Gastaut syndrome, typically present or debuting a little bit later on in childhood. And at the bottom, you also have some progressive syndromes, which also, I guess, can be considered DEEs, in that the epileptic activity and the underlying cause may both contribute to the developmental impairment. The diagram on the right, or figure on the right, gives a nice overview of when we might expect to see these syndromes in terms of their presentation. And as you can see, there is a variable age of presentation for some of them, which is quite wide, and for some of them it's relatively narrow. For example, Dravet syndrome we usually see in the first year of life, but it can extend a little bit beyond that. And the same for epilepsy in infancy with migrating focal seizures. So what is autism? It's characterized by social communication difficulties, repetitive interests or behaviors, an inflexibility of thought, and increased sensory sensitivity. So basically, it affects the way people perceive and interact with the world around them. It's very important to stress that it presents differently across individuals with respect to intellectual disability or abilities, co-occurring medical conditions, needed supports, and also the impact on everyday functioning. It has multiple etiologies, and many children with autism have co-occurring neurodevelopmental or mental health needs. And having pure autism without those, I think, is probably quite rare. Perhaps you don't even need a diagnosis. And both classification systems, DSM-5 and ICD-11, allow for a diagnosis of those co-occurring conditions. In terms of autism and epilepsy, it's worth first, reminding ourselves how frequent or how prevalent autism is in the general pediatric population. It usually affects about 1% or 1.5% of the general pediatric population. But what we see in the epilepsy population is a much higher prevalence. This systematic review from 2019 included 19 studies, and the total prevalence rate was 6.3% of autism and epilepsy. And particular epileptic syndromes had a higher prevalence than general epilepsy. So general epilepsy was 4.7%, but if we look at some of the DEEs, infantile spasm syndrome was 19.9%, and Dravet syndrome was 47%. So they're much higher in terms of the prevalence than general epilepsy. Another study which came out, another review which came out around the same time, found a period prevalence of autism in people with epilepsy of 9% when including all population types. So again, just under 10% of children with epilepsy or individuals with epilepsy have autism or are autistic. It's important to say that there is evidence that autism may be underdiagnosed in epilepsy or may be diagnosed at a later age. This could be due to lack of recognition, due to lack of screening or surveillance, but it also could be due to diagnostic overshadowing, where the focus is on the treatment of epileptic seizures, and the neurodevelopmental aspects are not given due attention. In terms of what genes are involved, this figure really nicely captures the range of types of genes, but also the specific genes. Comes from a publication from Nicola Spicchio and colleagues in 2022. And there are four main genetic subgroups, I guess you can describe them. So we have genes encoding for ion channels. So you see the SCNA genes there, which are often involved in the DEEs as well. Genes involved in synaptic function and structure. So we see CDKL5, SDX, BP1, and a range of others. And again, many of those genes are also involved in the DEEs. Genes involved in the mTOR pathway, including TSC1 and TSC2, the tuberous sclerosis genes. And we also have genes involved in transcription regulation, including SYNGAP1. So many of those genes which are associated with the occurrence of epilepsy and autism are also DE genes. I wanted to sort of talk a little bit about a specific DEE in order to illustrate how autism can present in the DEEs. You would be familiar, most of you will be familiar with Dravet syndrome. So it's usually caused, or in 80% or more of cases, it's caused by the SCN1A mutation. Onset is typically in the first year of life, but can go out to sort of 20 months. And it's characterized by recurrent focal clonic, febrile and afebrile seizures, and focal to bilateral tonic-clonic and or generalized clonic seizures. It's often considered the classic DEE with drug-resistant epilepsy, and the vast majority of individuals with Dravet have intellectual disability. In terms of the prevalence of autism, in studies that have used autism-specific instruments, it was noted that this ranged from 22 to 46% in a review of behavior and cognition in Dravet syndrome. What's also interesting is there has been a study looking at the prevalence of autism and Dravet in comparison with Lennox-Gastaut syndrome, and none of the patients in this study with Lennox-Gastaut reached diagnostic criteria for autism, while the prevalence in Dravet syndrome was 22%. So this was not a population-based study, and I think the prevalence in Dravet syndrome seems quite low and very low in Lennox-Gastaut syndrome, but it does show that there may be differences between various DEEs in the prevalence of autism. One question which has come up, is whether or not Dravet syndrome might be different with respect to how autism presents. So it has been suggested that autism might be underdiagnosed in individuals with Dravet syndrome because of their preservation of communicative skills and social skills or pro-social features. And this really points towards the need for a comprehensive team assessment. And it's very important not to rely on specific instruments, and that the gold standard is a multidisciplinary assessment and clinical judgment, as it is possible that children may not score in that risk zone by just using specific instruments, and it's really important to look at the child in the round and not just consider results of particular instruments. What we don't really have at the moment is any good data on whether one can reduce autistic symptoms or symptoms of autism in individuals with Dravet syndrome. We know with some of the new medications that are being used for individuals with Dravet syndrome, and I'm thinking, for example, of fenfluramine, that there is a hope and there is some data, although some debate on whether or not these drugs might reduce behavioral issues or executive functioning issues in these children, but we don't yet have any data on autism. I think it's also important just to sort of look at some data which just illustrates that, depending on the instrument used, a range of prevalences for Dravet syndrome can be found. In the study which we have undertaken using 3 different instruments, a social communication questionnaire, the autism subscale of the developmental behaviour checklist, and the ADOS, which is a structured observation, a different proportion of children with Dravet scored in the at-risk range. So 51% on the social communication questionnaire, 65% on the autism spectrum screener on the developmental behaviour checklist, and 65% also on the ADOS. So by just using screening instruments, you will get different prevalences, and the gold standard here will be consensus clinical diagnosis after multidisciplinary assessment. And in this particular study, we found that 61% of the children, with Dravet syndrome reached the DSM-5 criteria for autism, so the gold standard, and of those 46% had been previously diagnosed. So again, that issue of underdiagnosis is there. Another important point is that, when we look at Dravet syndrome, but also I think other DEEs, it's important to note that many children will have symptoms but may not reach the full criteria for an autism diagnosis. The data here comes from a study of Dravet syndrome we have undertaken. On the horizontal axis, you can see the age of assessment, and on the vertical axis, you can see the score on the social communication questionnaire. The red line is the cutoff point for at risk on the social communication questionnaire, which is a screening instrument for autism. And what you can see, firstly, in terms of age, there's no real pattern. You can have quite a lot of symptoms of autism regardless of what age you are in Dravet syndrome. But the other thing I think is worth to note is that many children, score just below the cutoff, and many children just above the cutoff. So when you use these instruments, there is a need to be careful in how you interpret them, because I think in Dravet syndrome, what we have found is that the cutoff of 15 is probably a little bit high, and a cutoff of 12 or 13 might be more useful. So actually, when you use a screener, it's important not to totally rely on the results with respect to cutoffs, because many children might score close under or over the cutoff, but they might not necessarily reach the criteria for autism on a comprehensive diagnostic assessment. Another issue which I think is important to discuss is whether or not there's a variable presentation of autism in the DEEs. And this has been suggested by a paper that came out in 2021, Holmes et al. And they argue that the phenotype of autism may not follow the usual trajectory and can fluctuate in the DEEs. So a more dynamic autism phenotype that can change over time as the child develops. The phenotype might look a bit different, as we've already mentioned, in Dravet syndrome. So a child might be socially approaching and socially interested, but still fulfill the criteria for autism. And one issue might be that challenging behaviour in children with epilepsy might actually be due to autism, but it is wrongly attributed to the medication or just that the child has epilepsy. So perhaps the child, isn't in an environment which is supporting their needs, and as a result, they may end up, displaying challenging behaviour or behaviour that challenges, whereas in fact they need an autism diagnosis to access supports and an environment that is supportive. There may be a reluctance to diagnose autism in profound and multiple intellectual disability, as the range of behaviours and reciprocal interactions is very limited, and it may be difficult to actually assess, but in some cases it might be useful even at that level of disability. And again, there may just be a reluctance to give an additional diagnosis of autism when the seizures are severe. So, to address, the question of whether or not a diagnosis of autism is useful in the developmental and epileptic encephalopathies, we found when we looked at predictors of quality of life in children with epilepsy that autism wasn't a significant independent predictor, but cognition and mental health difficulties were. So whether the child had intellectual disability or cognitive difficulties or mental health difficulties were the main predictors. Another issue might be, a lot of children with DEEs have severe profound disability, and the question is how low developmentally can you go? So if a child has a mental age or developmental age of under 1 year, is autism actually a useful diagnosis? And it's also pointed out that the relationship of autism to intellectual disability needs greater conceptual clarity, and actually intellectual disability needs more research, not just autism. Another point is that the current healthcare for autism practice is largely unevidenced, under great pressure, and its legitimacy has been challenged. So are the supports that are available actually useful for children with autism? Is there actually evidence that they work? Another question one might ask, and parents might often ask, is, do the approaches and supports for my child actually change with an autism diagnosis? So there are some issues which might need to be addressed, or some questions that might need to be answered in relation to the utility of an autism diagnosis in the DEEs. However, my view is that, the autism is not an overrated diagnosis in the DEEs, and it is a useful diagnosis. Hopefully, a diagnosis should lead to increased understanding and access to appropriate supports for both the child and family. Without a diagnosis, these children may miss out on interventions that could modify outcome, and their families and support teams will struggle to understand them. And in the study of Holmes et al. 2021, many families of children with DEEs have said that the most helpful outcome from the assessment has been the diagnosis of autism or intellectual disability rather than the actual genetic mutation. And there is some evidence that, interventions for autistic children can improve their symptoms, optimizing the child's early dyadic social communication and engagement within the family proves to be the intervention effect that best mediates subsequent long-term benefits in autism. And this has been shown in a number of randomized control trials, particularly with supporting parents and supporting their child's dyadic engagement. And we also know that children with DEEs might benefit from research, for example, natural history studies, if they have a diagnosis. One of autism, one better understands the natural history of the study of the condition. It's very important, though, to not forget that many children with DEEs and autism will also have a range of other difficulties, including sleep difficulties, difficulties with attention and hyperactivity, emotional behavioural problems, cognitive difficulties and intellectual disability, motor difficulties, and specific speech and language problems. So in this regard, it's really important to map out the child's needs and treat what you can. We know that ADHD and epilepsy, even in children with the intellectual disability, can respond to medication. In the general population, general pediatric population, training in motor skills can help function. There is evidence for psychological support for behavioural and emotional problems in epilepsy, including new data which shows that these interventions even work for children with autism and intellectual disability. And we also know that sleep problems can improve with intervention in children with epilepsy. To summarise, it is important to recognise autism in the DEEs. Improved understanding should arise, and also the child and family will have access to support and resources. Autism should be considered for all children with DEEs given the high rates, and it's very important to use a screening instrument if the instrument is useful with respect to age and developmental level, and don't overinterpret the results of one instrument. And don't wait too long. Many of these children have difficult to treat epilepsy, but that shouldn't be an excuse for not considering neurodevelopmental issues. Many children with the DEEs will have features, autistic features will not fulfill the criteria, but they still may benefit from approaches that work with autistic children. And it's equally important to provide supports for the other common neurodevelopmental issues and sleep that children with autism and the DEEs often have. Thank you very much.
Hi, I am Kette Valente, Chair of the Pediatric Commission. I'd like to thank the ILAE for organizing these webinars, and also I'd like to thank Stéphane Auvin for putting together this session and inviting me. I will be addressing behavioral and cognitive phenotypes in juvenile myoclonic epilepsy. These are my disclosures, nothing related to this lecture. Well, JME has been historically described since the 18th century, with some case reports that described mainly myoclonic seizures evolving with generalized tonic-clonic seizures, but the precise description of JME came from German with Kette Valente and Christian in 1957, and everything was considered. The seizure type, the EEG, the psychopathology, the reflex traits. However, it remained neglected or forgotten because it was described in German. And it was rediscovered later by Delgado Escueta and then Reilly Pascal, more than 30 years later, with the name juvenile myoclonic epilepsy and not impulsive petit mal of ES. Is an idiopathic generalized epilepsy with juvenile absence, childhood absence epilepsy, and epilepsy with generalized tonic-clonic seizures only, and it's the most frequent idiopathic generalized epilepsy. It's a polygenic epilepsy syndrome with a complex inheritance pattern, has already been documented in twins and triplets in different centers, and there is a higher risk of seizures for siblings of first-degree relatives and patients with JME, 4 to 8%. It's generalized for sure. The EEG shows polyspike, high amplitude, generalized polyspike and wave discharges. And if you look at more closer, then you can see, or closer, you can see the W of Jans. All patients have myoclonic seizures. It's a hallmark of this syndrome. 8% will have generalized tonic-clonic seizures, sometimes preceded by myoclonic seizures, such as in this patient. Then we may have myoclonic tonic-clonic seizures. And 30% will have absence seizures. As I said before, is the most frequent idiopathic generalized epilepsy and represents 5 to 10% of all epilepsies, so it occurs quite often. Photosensitivity is a major factor, is the most photosensitive idiopathic generalized epilepsy leading to myoclonic seizures during photic stimulation. There is a chronodependency for seizures that occur mainly in the morning when the patient is sleep deprived and requires lifelong treatment for most patients, but not for all. And although we know juvenile myoclonic epilepsy quite well, the misdiagnosis has been documented in high, low, and middle income countries. Why is that? Because JME, as we have learned over the years, is not so simple. It's a heterogeneous epilepsy syndrome. According to the Avignon consensus led by Dorothée Castellane-Trinité, we have the class 1 and the class 2. In the class 1, we have the most classical type, with myoclonic seizures occurring on awakening, especially in the first 2 hours. In EEG, we'll have those generalized polyspike and waves that I just showed. Normal or above normal intelligence, and the age at onset is narrow, between 10 to 25, 13 to 25, but peaking 15, 16. But in class 2, myoclonic seizures are not restricted to the moment that the patient's awake. They may occur mainly at that moment, but they may occur during the day. They are triggered by different stimulus, and the EEG may show some focalities and some asymmetries that may mislead the diagnosis. There is no mental retardation, no deterioration whatsoever, but you may not have a normal intelligence. And the age of onset, the window is broader, from 6 to 25 years. So we don't have homogeneity here. The seizure type at onset, the same. We may have myoclonic seizures preceding generalized tonic-clonic at the same time or following generalized tonic-clonic seizures. We also may have absence as the first seizure type, juvenile or childhood absence. In this type, when you have absence, these patients may have a worse prognosis. And in some cases, rare cases, we may have only myoclonic seizures. So we have subsyndromes in this syndrome, and it has been very well documented by Delgado-Escueta's group, with 257 patients followed for decades. So we have the classic JME, 7%. We have childhood and juvenile absence epilepsy evolving with JME, and we have a very rare type, JME, with atonic seizures. The reflex traits, as I mentioned before, the most frequent photosensitivity is age-related, from 90 to 38%. 38%. The earlier, the younger, the most sensitive or photosensitive. We may have praxis induction, we may have orofacial reflex myoclonic seizures, and eye closure sensitivity, described also by Jens. That's quite rare. And about the EEG, how focal is the EEG? Well, we may have this amplitude asymmetry. It's not only about amplitude if you compare the left and the right. We may have more discharge on the left than we have on the right, or on the right that we have on the left. It's misleading. And we may also have focal onset and focal offset of the epileptiform discharge, focal epileptiform discharge. Here in the same patient, we have generalized and focal abnormal morphology of the epileptiform discharge, and this fast rhythm that may resemble a Lennox-Gastaut rhythm, that's in Lennox-Gastaut syndrome, and it's a marker of drug resistance in patients with idiopathic generalized epilepsy, not only JME. What about the prognosis? Most patients will have seizure control with proper anti-seizure medication, and 15 to 20% will be drug resistant. We also can have or may have pseudo-refractory JME. We have to be careful about that when they are not properly treated. And about anti-seizure medication, what is the amount or the percentage of patients that can be not only seizure-free, but anti-seizure medication-free? Then we have that 70% of these patients will remain under anti-seizure medications, here followed for more than 25 years, and 30% may have a discontinuation of their anti-seizure medication, in general 20%. And the most important factor to know who is the complete remission of generalized tonic-clonic seizures after treatment. So we have, and it's clear, a heterogeneous syndrome regarding seizure type at onset and during follow-up, regarding EEG, prognosis, if we need or not treatment, long life treatment. What about psychopathology? Because when we discuss psychopathology and JME, we have a tendency to say that patients with JME have behavioral and psychiatric disorders. Patients with JME have executive dysfunction and impulsive traits, and it will impact their social life, their treatment, which may lead some authors to use this very nice title, A Wolf in Sheep's Clothing. Is it so? Let's address first behavioral and psychiatric disorders. The first descriptions that we have, they come from clinical observation, no strict criteria. And then we have a group of patients that are described as unsteadiness, with unsteadiness, lack of discipline, indifference towards epilepsy, and emotional instability. Interestingly, in the same articles, for some authors, there is no social or health consequence, which is quite unexpected. The first attempt to describe these patients with some criteria comes from the School of Marseille, that was extremely important and described psychiatric disorders as we understand now in JME, using the modern psychiatric nosography. They were the first to describe the frequency and not to generalize for all patients. So 20 to 30% of JME patients have psychiatric disorders. They occur more often in patients with drug-resistant epilepsy. It's not a cause and consequence, just a correlation. And following the DSM, at that time, the DSM-4, we have in a large sample 26.5% of all these patients with psychiatric disorders, 20 to 30% with a personality disorder related or associated with impulse control. Some of them may have a borderline personality disorder. When we say borderline personality disorder, we think about self-mutilation, self-harm, suicide attempts. It is not what we have in JME. This was emphasized, stressed by Janton and Jalise. We have mild to moderate personality disorders. They are more associated with impulse control, and they have consequences, of course, but not what we see in other patients. Is a more typical phenotype, more specific phenotypes. Over the year, we have some papers, articles describing the frequency of psychiatric disorders, emphasizing the frequency of anxiety, depression, and also some very high rates of personality disorder, which led the Marcelli School of Epilepsy to stress in an editorial that some degree of psychological and social dysfunction may be expected, but we should be careful not to overrate them. So I think we can say at this point that psychiatric disorders will occur in 20 to 30% of these patients, more often in those with drug-resistant epilepsy, and 20% may have personality disorders, even the borderline type, associated with impulse control, but we must expect a mild and moderate mild phenotype. Regarding executive dysfunction, is it a hallmark in this syndrome? It seems to be. We will see a lot of aspects that we see, for example, in patients with ADHD, difficulties to establish one clear goal, to delineate one strategy, to change, to switch, cognitive or mental flexibility when this strategy does not work, to have good attention from basic to complex tasks, especially sustained attention. It will have an impact in working memory and may have an impact in prospective memory. Decision-making, which is considered a hot executive function because it's associated with emotion and it's not part of the most classical batteries, is also impaired and explains somehow some of these problems with not taking and seizure medication, even when you know the risks. It's easy to explain. And it's really impressive in decision-making how it seems that we have two syndromes here. When we look at patients with seizure-free status and decision-making, they are closer to health control than they are of other patients with JME, not seizure-free, that really perform not well. And there's that. So we have different profiles for sure. In self-assessment scales, these patients report everyday life problems with these executive traits and also with the impulsive behavior. But it's self-assessment. Trying to provide a group stratification instead of generalization, we assessed 42 patients with classical JME, meaning most of them easy to control. And what we found is that 60% or 63% had an executive and attention impairments in different levels, not at the same, and not in the same depth, not with the same deficits. Another study with a different sample, drug-resistant JME, also with a comprehensive battery, also showed 66%. But when we look at the type of deficits, we see that it's beyond executive and attentional deficits. This is the difference. It's not always the same. As a genetic epilepsy, as we mentioned before, these traits we can find in siblings. And we may have the same traits that may be more severe in patients with JME than in their siblings. The stratification would be JME is worse than their siblings, but their siblings are also worse than controls. Impulsive traits. Well, there is a pioneer description about impulsivity in JME that is used even in these days and has to be. It's a seminar description by Jans. It's about impulsivity, emotional instability, mood changes, and they have a negative impact in social life and treatment, as I mentioned. However, we have to understand that impulsivity is a spectrum from traits that are absolutely necessary to disorders. And what is JME, after all? That's the thing. Using an inventory, this is the Cloninger inventory that is considered a gold standard inventory for symptoms, not disorder, because disorder, we need a psychiatric interview. So symptoms, we can observe that these patients, we document that these patients, they are novelty seekers, but also unexpectedly, they have a very high harm avoidance, meaning that they learn in a simple way. They learn with negative feedback or with their mistakes. It's a very particular profile that we cannot compare with pathological gamblers or substance abusers and users that also are very impulsive people. But with this profile, which means that they may be good candidates for rehabilitation. These impulsive traits, they are worse in patients with hard to control epilepsy compared with easy to control JME, as we observed in everything since the beginning. For this reason, some years ago, we decided to study a very homogeneous sample of patients with JME, which is very hard in a tertiary care sample, to respond to these questions if we should, because it was a concern at that time, as it is a concern now, as I speak, if we should address these patients as equally impaired, or if we should classify them under the same umbrella. And for this, we selected 57 patients with classical JME. They were all under valproate, using valproate. We didn't want a lot of polytherapy or other drugs that may impact mood or cognitive aspects, such as topiramate, lamotrigine, mainly levetiracetam. And we divide according to the amount or the dose that they needed to be controlled. They were controlled. We used a comprehensive neuropsychological assessment, and they all had neuropsychological and psychiatric evaluations. And what we found is that patients with harder to control seizures had more impairments in executive performance, but also in memory. And this was the first time that we realized that there is a very controversial thing about memory in JME, is that we must always look at the sample. Patients in tertiary care centers, they may have memory deficits, but they are very selected sample. We have to pay attention to that. In general, patients with JME do not have mnemic issues as we see in temporal lobe. It's not expected, but harder to control JME may have a worse performance, even in memory. And also, as expected, and as I mentioned before, they have higher scores in Cloninger inventory and in Burra impulsive scale, for impulsiveness. There is a correlation, but as I mentioned before, correlation is not causation. We cannot say, as we do very often, is a marker, is a predictor, there is an impact. It's not like that. We have evidence from very nice neuroimaging studies that we have a more diseased cortex or a more dysfunctional cortex, and these patients with harder to control GME, cognitive deficits, more severe cognitive deficits, and psychiatric disorders. I will just mention one. There is a pioneer study by Ivanka Savinky from Karolinska Institute with spectroscopy, showing that patients in general with GME have a reduced frontal lobe concentration of N-acetyl aspartate. That's a marker of neuronal function or dysfunction in this case. But those patients that perform worse in some neuropsychological testing, like in this case, it's a very restricted battery, but using trail-making test, they have lower levels of N-acetyl aspartate compared to others. Well, so I think we discussed psychiatric disorder, executive dysfunction, impulsive traits. There are mainly traits, not disorder for most patients, and the impact. We know that impulsivity has a higher impact, and there's a higher impact on social adjustment scale. And when we say social adjustment scale, I don't say quality of life. We didn't use quality of life scales because quality of life that is important is based on the patient's perception. And here we measure work, social, leisure, family, relationships, economic stability, financial aspects. So impulsivity and seizure frequency are the most important things for these patients. And is it possible to help them rather than describe their deficits over and over? And this is what we tried in a preliminary study recently published. We started with 42, actually we started with 68 patients, even more, and we end up with 42 patients. And some of these patients didn't fulfill the criteria or didn't meet the criteria to have rehabilitation. Then we rehabilitate 28 more severe cases. We didn't include patients with personality disorders because rehabilitation for borderline personality disorder is another type of rehabilitation. It's a very comprehensive battery before and after. And we use different types of rehabilitation or apps for those that like more the digital thing than digital. For those that don't get used with digital, then more analogical. And they had tasks, 16 sessions, and after that, there was an improvement, an objective improvement, and cool and hot executive function that was surprising, decision-making, and implicit and explicit decision-making, also an improvement in attention, inhibitory control that is very important for impulsivity and mental flexibility. And in self-assessment scales is more subjective than in brief for executive function and in severity of attentional symptoms. Also in BIS that assess the impulsive control. So I think that now it's fair to say that we will have psychiatric disorders for 20 or 30% of these patients, executive dysfunction 60%, impulsive traits are mainly traits, not disorder, that we can rehabilitate them, and for some it may impact adherence and risk behaviors. So I think that now we can treat these patients in a different way. They have a lot of things in common, but they are not the same. So persons living with JME are not the same. Okay? In the moment that we are discussing precision medicine and personalized approach, maybe a personalized approach for JME and idiopathic generalized epilepsies, and for all epilepsies, it's mandatory. Because we will have syndromes, but they are quite heterogeneous. Thank you.
Thank you for inviting me to take part in this very interesting webinar. The main topic of my talk is the comorbidities in focal epilepsies with onset at variable age. This is my disclosure. I'm going to discuss with you the role of comorbidities in the new classification of epilepsies, and I will focus mainly on depression and psychosis, and I will just touch other behavioral symptoms and the role of psychiatric comorbidities in general. As you know, now epilepsy is defined not just by the enduring predisposition of the brain in generating seizures, but also by the cognitive psychosocial consequences of the disease. So with the new definition of epilepsy in 2014, psychiatric comorbidities became part of the definition of epilepsy itself. With the new multi-axial classification of epilepsy syndromes, comorbidities become as important as etiologies in the definition of the epilepsy syndromes. And this is another important step in the role of comorbidities in epilepsy syndrome classification. So the main focus of my talk is this specific section, focal epilepsies at variable age. So let's start with the number of genetic syndromes that are part of this group of epilepsies. And let's see whether any of them is associated with a specific psychiatric comorbidities. In general terms, the number of data is very limited. There is something about sleep hypermotor epilepsies with some genes associated with depression. There is something for the familiar focal epilepsy, NPRL2, maybe associated with some schizophrenia trait. But for the majority of these syndromes, we have no data at all, whether they can be associated with specific psychiatric comorbidities. We now have a very good data about the epidemiology of psychiatric disorders in adults with epilepsy. For depression, we have prevalence rates for active epilepsies, for active depression in people, in unselected group of people with epilepsy, up to 25%. That is almost 3 times higher than in the general population. But it is the relationship between epilepsy and depression is definitely more complex than that, because not just epilepsy is associated with increased risk of depression, but also depression is associated with an almost 3 times increased risk of developing epilepsy. What a number of epidemiological studies have shown is that the increased prevalence predates the onset of the other conditions, sometimes of many years. For example, for depression predating epilepsy, we can see that there is a increased in the prevalence shortly before the onset of the epilepsy. In this way, it is really tempting to speculate that depression represents a sort of a premorbid state or premorbid symptom preceding the onset of the epilepsy itself. Why such a complex relationship? On one hand, we know that there are a number of brain structures and brain networks that are involved in depression that are also key in epilepsy, especially in temporal lobe epilepsy, like the cingulate cortex, the dorsolateral prefrontal cortex, the hippocampi. We know from basic science studies, for example, that abnormal serotonin levels and abnormal serotonin transmissions are present in all major animal models of epilepsy. The hyperactive HPA axis, that is a typical neurobiological model of depression, is associated on a long term with damage in the hippocampal neurons, reduced BDNF, downregulation of GABAergic receptors that ultimately lead to an increased risk of epileptogenesis. However, the scenario is definitely more complex than that. In this systematic review of neuroimaging studies of patients with epilepsy and depression, we identified a number of critical differences between depression outside epilepsy and depression in epilepsy. First of all, the areas involved in depression are different in the hippocampi, are different from hippocampal sclerosis. The other relevant point is that hippocampal changes in primary depression are reversible, and these have been demonstrated by a number of studies, while hippocampal sclerosis is not a reversible process. In primary depression, there is mostly a cortical involvement, and very rarely subcortical structures are involved. This happens mainly in early onset depression, with onset in childhood or adolescence, where, for example, amygdala are involved, while in depression in epilepsy, subcortical structures are almost always involved. The pattern of changes is different, with smaller amygdala in primary depression and enlarged amygdalas in depression in epilepsy, as well as differences in the default mode network. So if we look at the pattern of subcortical and network changes, depression in epilepsy is a different phenotype from primary depression outside epilepsy. This obviously reflects the complexities of depression in general, that in the case of epilepsy is probably due to a combination of different factors. Some clinical factors shared with the general population, biological factors specific of epilepsy, like the involvement of specific brain functions or neurotransmitters imbalance, but a number of psychosocial factors, the chronic nature of the disease, the fact that epilepsy is still today a highly stigmatized condition, difficulties in adjustment, fear of seizures, unpredictability of seizures, overprotection, low self-esteem. So depression there are many different types of depression in people with epilepsy that lead to the increased prevalence, but we are unable to identify at the moment a specific phenotype. In general terms, it is pretty evident that depression is an index of disease severity, because in seizure-free patients, the prevalence is the same of the general population, and this increases to unselective samples up to 50% in drug-resistant samples. This is beautifully shown by long-term studies in depression and epilepsy surgery, because on a long-term, in very long follow-up studies, it is possible to see that the prevalence of depression follows the outcome of the surgery. So in patients that became seizure-free, also depression improves or goes into remission, while in those where the surgery is unsuccessful, then depression has a relapse and ultimately follows the outcome of the epilepsy itself. However, studies in psychiatry have shown that specific structures in the limbic system may have a transdiagnostic role. In particular, data from the ENIGMA consortium, that is a large international consortium of neuroimaging data in major depression, have shown that the involvement of the hippocampi represents a key transdiagnostic element, meaning that it is more and more involved and more atrophic going from depression to bipolar disorder to schizophrenia. The involvement of temporal lobes in psychosis is evident also in epidemiological studies in epilepsy, because if the prevalence of psychosis in unselected samples of patients with epilepsy is 5 times higher than the general population, if we look at temporal lobe epilepsy specifically, the prevalence is 7 times higher. These already suggest that temporal lobe involvement represents a risk factor for the development of psychosis. Data in epilepsy are in keeping with those in primary psychiatric disorders, suggesting that psychosis is a marker of severity of basal temporal lobe pathology in epilepsy. In unselected temporal samples of patients with temporal lobe epilepsy, the prevalence is higher than in the general population, but going to unilateral hippocampal sclerosis or to bilateral hippocampal sclerosis, then the prevalence of psychosis become more and higher and higher. However, epilepsy is a network disorder, and a systematic review of structural and functional alterations in psychosis of epilepsy has shown that there are a number of changes in areas that are distant from the primary focus in temporal lobe epilepsy that may be responsible for psychosis. In this way, it is tempting to speculate that people with temporal lobe epilepsy and psychosis represent a different and specific phenotype. We have data, again, pointing towards the role of temporal lobe structures, also from studies looking at psychiatric reactions to anti-seizure medications. This is a large sample from the Melbourne group, where they looked at psychotic episodes triggered by anti-seizure medications. And again, they have identified temporal lobe involvement and previous psychiatric history as key elements, but with the temporal lobe involvement definitely more relevant than the history of psychiatric disorders, and then also the effect of specific drugs like levetiracetam. Data from the levetiracetam in particular are pointing towards also the interaction between brain structures and specific genetic background. In these pharmacogenomic studies in people with levetiracetam who had a psychiatric adverse event, they clearly showed that the background genes for schizophrenia are quite predictive of the levetiracetam-induced psychosis. Definitely not specific genes, but those that are involved in schizophrenia play a role in the development of this specific side effect. In depression, probably the background depression is more relevant than the presence of specific brain structures. In this study dating back to many years ago, we looked at the role of different factors for the onset of depression with topiramate. If we look at the rapid titration only, this was associated with around 5 times increased risk. If the rapid titration happened in someone with hippocampal sclerosis, the risk of depression was only slightly increased, while the rapid titration in someone with a pre-existing depression increased the risk up to 23%. This study shows that in this specific case, for example, in that of depression, the background alterations, the presence of depression is definitely more relevant than the involvement of temporal lobe structures that show to be implicated in psychosis mostly. Then we have other behavioral traits, like, for example, obsessionality. This is a study of many years ago, at the very beginning of my career, where I was interested specifically in the Gershwin syndrome. We looked at the prevalence of and main characteristics of obsessionality in people with temporal lobe epilepsy as compared to generalized epilepsies. And in this study, we showed that obsessionality in particular was significantly more frequent in people with temporal lobe epilepsy rather than those with generalized epilepsies that were pretty similar to healthy controls. And this was not related to the severity of the disease, because seizure-free patients had exactly the same pattern of symptoms as patients with very high seizure burden. For other traits, like, for example, deficits in social cognition or difficulties in emotion attribution tasks, while at the beginning some studies pointed towards a specific association with temporal lobe epilepsy, subsequent studies showed that the same sort of problems are present also in generalized epilepsies. But in general terms, psychiatric disorders are associated with poor quality of life, increased risk of SUDEP, but also cognitive side effects of anti-seizure medications, increased mortality rates. In general, psychiatric comorbidities in people with epilepsy are specific prognostic markers. So epilepsy is a brain network characterized not just by seizures, but also by behavioral symptoms. Behavioral symptoms as part of brain network changes involved in emotional processing and cognitive functioning. Mesial temporal lobe involvement obviously carries an additional risk, so temporal lobe epilepsy seems to be associated with an additional risk, but at the moment it is not possible to specifically identify red flags in specific focal epilepsies. We have to consider the individual background, the genetic predisposition given by the previous history or family history. At this stage, with the information that we have, we therefore need to still screen routinely all patients, and we cannot say that there are specific psychiatric comorbidities in specific syndromes. For future studies, we'll need to identify specific clinical phenotype in order to inform patient, develop specific treatment strategies, and identify prevention strategies. Thank you for your attention.
Welcome to this last talk of the webinar. I would like first to thank the Pediatric Commission and Kette Valente for the organization of this webinar. Today, this last talk will be about how to use the 2022 ILAE classification, syndrome classification, as a roadmap for comorbidities. Then first, this is my disclosures. When you think about the organization of epilepsy, the 2017 paper, you know that we have 3 levels of organization: seizure type, epilepsy type, and epilepsy syndrome, when we are able to do it. And from the start of this organization, in addition to these 3 levels, we have the etiology categories and the comorbidities that is coming from seizure type, epilepsy type, and epilepsy syndrome. For a long time, it has been clear that we have different types of non-seizure outcome. A lot of us are focusing on cognitive and psychiatric, but there are also other non-seizure outcomes. We already addressed today depression and anxiety. We address executive function and autism spectrum disorder. I will try to cover a bit of ADHD and intellectual disability, and we will try to have a global overview on how to use the classification as a roadmap. For a long time, it is clear that some etiologies could lead to the understanding of what could be the comorbidities, and one of the best examples is probably tuberous sclerosis complex, where all this non-seizure outcome has been described as sound, tuberous sclerosis complex associated neuropsychiatric disorders that could be at the behavioral level, psychiatric level, intellectual level, with consequences that could be at the academic level, neuropsychological level, and psychosocial levels. This has been described not in a syndrome, but most likely under the umbrella of an etiology. And we will see today how we can use our syndromes to discuss that, as mentioned by the previous speakers. Then let's move to syndrome that could be used as a roadmap. I would like first to discuss around the syndromes that are developmental epileptic encephalopathy and syndrome with progressive neurological deterioration. I will focus more on the DEE first. Looking at the DEE, all the intellectual disability, involvement, or the behavior trouble are not the same in all these syndromes. We know that there are two components in what we call DEE. The D for developmental part, most likely related to the etiology, and then this is a part that is fixed, and the epileptic part that is related to the seizure and the epileptic activity. At some point, we can still discuss about the interictal EEG abnormalities that might have a role in the case of intellectual disability. This is not only conceptual. I mean, it could be something very important for each patient to ask yourself. Is it the developmental part that is more important or the epileptic part that is more important? Because when it comes to treatment, if you think that the epileptic part is the more important part for the cognitive involvement, you will definitively reinforce, increase your anti-seizure medication or your anti-seizure strategies. While if you think that is a developmental outcome, you will be very careful increasing, in particular, treatment when it's related to anti-seizure medication, just to avoid to have an extra burden that is coming for your treatment. In that case, we know that there are different ways to have cognitive involvement. It could be after a while, if you think about time and development, it's never linear for sure, but in some of these patients, you observe a plateau that could be related to the start of the epilepsy. For some of these patients, it's more than that, it's regression, and you have like some ability that is disappearing, and it's probably something that we have to be aware and to look for, because it's probably one of the emergency in the case of the. Let's move now with some example. One of the first example I would like to discuss is Lennox-Gastaut syndrome. There are different scenarios for Lennox-Gastaut syndrome. One of them, one of the most frequent, is patients that always had an intellectual disability, and sometime during late infancy or early childhood, the epilepsy is starting with different types of seizures, including tonic seizures and interictal abnormality with the slow spike and waves, and then the full phenotype of Lennox-Gastaut is observed. We know that in these patients, there are improvement and worsening over time that is most frequently related to the epileptic activity. Then reinforcing the treatment to improve the cognition and the behavior, and be careful always on the developmental side not to be too pushy with the anti-seizure medications that could also worsen this patient. There are other scenarios that patients that were normal and with an acute neurological injury like encephalitis, multiple stroke, or severe TBI, these patients are left with a severe brain damage and they develop different types of seizures, and same thing, you can see this fluctuation. About 30% of these patients are coming from infantile epileptic spasm syndrome, and then the epileptic spasms start to last longer, turning to tonic seizures and different types of seizures, and then the EEG pattern. And when they fulfill the criteria, once again, the cognition is fluctuating, with the epileptic activity. It's still very unclear what are the underlying mechanisms, and we definitely have to further understand what is ongoing to make sure to develop specific treatment for the non-seizure outcome and prevent the consequences of this syndrome. Moving to another syndrome, I would like now to discuss around ISWAS. These patients have few seizures that are not difficult to treat around the age of 6. And after a few months, they develop multi-type of seizures associated with a regression, meaning they are losing abilities they were able to do, and this regression is associated with spike and wave activation during the sleep. Could be generalized, could be focal, but it's definitively a worsening of this spike and wave discharge during the sleep. Eventually, if you, with your treatment, you resolve this EEG pattern during the sleep, the patient may regain the previous or partially the previous cognitive abilities. The main characteristic, and this is the key factor to identify ISWAS, is the cognitive regression that is a pillar of this syndrome, more than the EEG pattern that could be seen sometimes in patients with intellectual disability, but not with ISWAS. We know that ISWAS or DISWAS, in case of the developmental part before, is most likely a spectrum where we used to have 3 entities: the atypical benign focal epilepsy of childhood, the Landau-Kleffner, and the epileptic encephalopathy with continuous spike and waves. We know that some of these patients are coming from self-limited epilepsy, like SELECT or SELAS or CO, but some are coming from structural abnormality, epilepsy with focal seizures, and a structural abnormality like polymicrogyria. Some of these patients, starting for epilepsy with focal onset seizures, will turn to ISWAS or a DISWAS, and we have to further understand what explain or what predict this switch from a non-DEE, no EE, to a EE-DEE phenotype that leads, unfortunately, to regression that could be seen at the cognitive level, at the behavioral level, at the motor level, but also with some autistic features. The last example I would like to discuss today is about Dravet syndrome that is definitively more complex to what we initially thought. This is an example of one of the few cohorts that has been published looking at cognition. This is the evolution that is definitively related to an intellectual disability. Looking prospectively at this cohort, they show that it was a significant decrease over the age, but not a regression. And in this cohort, they did not find any correlation between the intellectual or the developmental quotient or the intellectual quotient with some epilepsy data. For example, the first seizure, the seizure during the course, the number and the age at the first status epilepticus. But something that was related to the level of intellectual disability was the fact that the patients had or not the SCN1A pathogenic variant. This is coming to some experimental study that look at the function of SCN1A on cognitive level. This is a very smart experiment. When they use normal mice, they use sRNA to stop the expression of SCN1A in these normal mice. And this injection of the sRNA was done in the medial septum and the diagonal band of Broca. This is an area that is rich with GABAergic interneuron, and these interneurons are involved in the spatial memory. In addition to that, when you have a spatial memory, you have a biomarker of the cognitive task related to what you can record as a theta oscillation. They use 2 types of mice. Some mice injected with the sRNA, some mice not injected with the sRNA, but a sham group. And they train them in an arena with 3 objects like that. And then after the surgery and the injection of the sRNA, they did 2 cognitive tasks. The first task was the spatial memory, moving the object. The blue object is moved. And then the second memory is a novel object recognition. They change the triangle green to a square green. That is a novel object recognition that is not related to this medial septum and the diagonal band of Broca. Then, when you look what happened, mice are very curious, and when you train them, they are looking with these three objects in the control group, as well as is the siRNA group, that is the group injected with the siRNA. And then after surgery, when they receive the siRNA, you can still train them in the same arena. When you move the object, you can see that the control mice spent a lot of time around the object that has been moved, showing that they got these special changes, while the siRNA, they did not get it. For the novel object recognition, you can see that both groups recognize it. When they look at the theta oscillation correlating the spatial memory task and the theta frequency, they found a correlation in the control group, no correlation for the spatial memory for the SCN1A group, and both correlated with the object recognition and the theta frequency, showing that with this experiment, no epilepsy at all. You can interfere with cognitive processes if you have change in the SCN1A expression. Another interesting study was the Dutch cohort when they look at what they call the contraindicated medication, that is most likely sodium channel blockers that were used. And they show a correlation between time exposure to the sodium channel blocker and the developmental outcome. When they tried to separate this population in two groups, they showed the best and the worst group on cognition. And then how to differentiate these two groups was less or more than 11 exposure to this sodium channel blockers that were called contraindicated medication, suggesting that a long exposure to worsening impacts the long-term outcome. In the other way around, if you look this open label study after the fenfluramine trial, looking at the brief, 1 year exposure improves some of the subtests of the brief, like emotional regulatory index and the cognitive regulation index, were different between the responder and the non-responder after 1 year of exposure, suggesting once again that a long-lasting improvement might reverse in part some cognitive function in Dravet. When thinking about Dravet, we know that the cognitive involvement is related in part to the gene. Of course, the status epilepticus early in life has been shown as a factor in the first cohort before the use of stiripinol. Some worsening, like with some contraindicated medication, can worsen in part the cognition, but if you improve for a long-lasting period, about 1 year, you might also improve or decrease a part of this cognitive burden. This is how we looked at and what is your knowledge currently for this syndrome. Let's move to other syndrome now, and I would like to discuss a bit about generalized epilepsy syndrome, where you have this genetic generalized epilepsy that could be divided in the genetic generalized epilepsy itself and the subpart that is the idiopathic generalized epilepsy. It has been addressed by Kette, and I would like to focus on childhood absence epilepsy. In addition to childhood absence epilepsy, one of the comorbidities that is common between childhood absence epilepsy and some self-limited epilepsy, so select self-limited epilepsy with centrotemporal spike and self-limited epilepsy with autonomic seizures, we know that the most common comorbidity at this age in these three syndromes is ADHD. Then in epidemiological study, we know that ADHD is around 10% of the general population, but in case of epilepsy, it could be up to 30–40%. That is 2.5–5.5 more than the general population. It's not only a symptom, it impacts quality of life and is strongly related to an increased risk for academic underachievement. There are two bidirectional relationship between ADHD and epilepsy. We know that ADHD is a risk for epilepsy, but epilepsy is a risk for ADHD. We already mentioned the new onset and the select SELA and the childhood absence epilepsy. Something that is very special is the subtype of ADHD in the epilepsy patient. The clinical picture for a child neurologist of an ADHD patient is the patient with the hyperactive component. The parents are coming to your clinic because they are exhausted. The teacher is exhausted. All the caregivers are exhausted by the kid because of the hyperactive part. But in case of the epilepsy patient, the inattentive part is more frequent, meaning they are making attention deficits and mistakes during their academic evaluation, but in a quiet way because they are not hyperactive. So meaning if you are not screening them, you will miss the diagnosis, or you will find out the diagnosis when the patient, unfortunately, will meet academic difficulties. We know that we have treatments. A lot of these treatments are psychostimulant. Most of the study has been done with methylphenidate. It's mostly class 2 and class 3 study, as you can see, with a good improvement. In the SMPC of the methylphenidate, it's frequently written that it's contraindicated in epilepsy patients. It's not, as it has been mentioned in this systematic review done by the Pediatrics Commission a few years ago. And the seizure worsening might exist, but very frequently lead to discontinuation. Then if we look globally to this syndrome, the 2022 classification, using as a roadmap, it has been addressed today with some of the idiopathic generalized epilepsy, like GME, with the executive function. Some of the epilepsy with focal onset in adult temporal lobe epilepsy, anxiety, depression. I mentioned today the DEE and how the cognition and the behavior could be impacted. Colin also addressed the question of autism spectrum disorder and the link between intellectual disability, brain disorder, and autism spectrum disorder in the case of epilepsy. It's not one picture. There are many things that we still have to understand there. And lastly, I discuss the ADHD. Then we definitively have something to move on, better understand what are the comorbidities, how they are linked with the syndrome, better define the syndrome using also the comorbidity. And then I would like to thank you, and thank you again for your attention.
Thank you very much. Thank you all. I'd like to invite Colin, Reilly, Stéphane Auvin, and Mula to open their cameras. And now we have our Q&A session. So we have some questions here, and I think the first one's for Colin. Response to management of autism spectrum disorder in this case still depends on the control of seizures, right? What do you think, Colin?
If I understand the question correctly, Kette, it's around supporting individuals with autism or autistic individuals. And I think the key thing is, optimize seizure control. That may not be seizure freedom. And that will, that's very important. And then when thinking about supporting autistic individuals or individuals with autism, it's very important, as I said in my lecture, to consider the other co-occurring conditions. So when supporting individuals with autism, it's very important to think about cognitive ability, if the child has an intellectual disability or not. And I don't like the idea of treating the autistic symptoms. I think it's better to think about supporting the individual with autism in terms of the environment, but it will depend a lot on those other co-occurring conditions such as sleep problems. And as I said in the lecture, you can treat many of those particular co-occurring conditions, and then you need to think about how best to support the individual with autism after optimizing control of epilepsy, whatever that might be.
Yeah, I'd like to just to add to this response, Mike, that we have some evidence that we have a lot of evidence, robust evidence that is not only a consequence of seizures, so seizure control may not and will not represent the response to the autism spectrum disorder manifestations. Stéphane, do you want to comment on this one?
I mean, I agree with you. Yeah.
Okay. So we have another question from Dr. Rick Gwenan. Nice lecture. Should we avoid anti-seizure medications with adverse effects, psychiatric adverse effects, when we should switch to anti-seizure medication from one to another, I believe? When can we give aspartate for dietary on JME patients? Well, I think it's about JME, juvenile myoclonic epilepsy, but we can extend to other types of epilepsies, and we should not avoid anti-seizure medication. We should treat the this was psychiatric disorders or cognitive deficits. There are some concerns about levetiracetam and mood, phenobarbital, and mood and cognition, topiramate and cognition. So in this sense, yes, but still the main goal, the cornerstone of epilepsy is seizure control. But we have to treat as well the psychiatric disorders. I wouldn't say that we have to change or switch from anti-seizure medications to any type of dietary treatment. Marco, would you like to comment on this one, please?
Yeah, thank you. I agree. I think that, first of all, our job is obviously to inform patients and families about side effects of medications, but we should not take a decision actively on behalf of our patients. Our job is to recommend the best treatment in order to control seizures completely. So what I say to my patients when I have to start, for example, levetiracetam in JME, is obviously if they have a psychiatric comorbidity, they are at increased risk compared to another patient without. But I say that in any case, this side effect doesn't happen in 100% of patients. It should be evident at the very beginning. They should get in touch with us. And when the drug is discontinued, the side effect goes away. So we should show to the patient that we are able to handle situations rather than take actively decisions about avoiding drugs that may be very beneficial for some patients.
Can I add something?
Yeah, sure.
On diet, except ketogenic diet or modified Atkins diet, because we have evidence-based data on the fact that it's active on seizures, but it's mostly for drug-resistant epilepsy, except GLUT1 deficiency and pyruvate dehydrogenase deficiency. But I mean, for the other diets, there are a lot of ongoing discussion, in particular on the social media. But until we don't have evidence, we can put our patients at risk on something without evidence for efficacy and risk for some side effects. And even this diet, we know that diet could have side effects or could be ineffective. Then the benefit-risk ratio in that case is not good. Then we have to be patient or conduct research.
Perfect. We have one question here that's beyond our lectures, but it's something that Stéphane has addressed very often, and I have done the same. It's about abnormal sleep EEGs in patients without seizures, but with the autism spectrum disorder. Stéphane, would you like to address this one?
Yeah. I mean, if you think about patients with autism spectrum disorder, the more you record them, the more EEG abnormality you will get. If you record 1 hour, 20–30% without epilepsy have abnormal EEG. If you go for a sleep or a 24 hour, it's up to 60% of these patients. there are something ongoing. You know, it's a biomarker or something, but not indicating that you should treat them. Most of these patients are very sensitive to anti-seizure medication side effects, and then most likely you will worsen the patient than improving anything. In case of seizures, of course, it's a different story, but your aim of treatment, putting anti-seizure medication in this patient, will be seizure freedom, not improving the EEG.
You just answered the second question, that is it needed treatment of the EEG under no circumstances. And the thing is, Stéphane, I'd like you to respond to this one. Do you request EEGs for children with autism spectrum disorder? Is there any specific situation that you think about EEGs and just that one, or you don't request at all?
I don't request EEG on a regular basis. And when parents or caregiver complain about behaviors that could be seizures, I first ask a lot of videos. And then I start by assessing the video first, but because when you think about how to do an EEG recording in a patient with autism spectrum disorder, from the start, we know that it could be something very difficult for the patient and the family. Then based on that, I will decide first going from videos, and if it's still very suspect, I will do for the EEG recording.
Perfect. We have one trick question here, is more a case. In epilepsy patients with nonverbal autism, I think it's one specific case here, who are still under valproic acid, meaning anti-seizure medication. If he has never had a seizure for 2 years, but there is still no change in the EEG evaluation, there is PLES, periodic lateralized epileptiform discharge. His anti-seizure medication is still given or necessary. His MRI was normal. Well, in general, we don't discuss cases because this is a very short thing about one very complex case, probably, but we can try to address this question. Would you continue to prescribe anti-seizure medications for a child without seizure, with a normal MRI and a very abnormal EEG? I think this is the summary here. My response would be that it depends on the case. It depends on the patient. Some patients we know that will have seizures if we stop the anti-seizure medication. And this one with periodic lateralized epileptiform discharge, I would like to know, we don't call like the more, but anyway, I'd like to know the etiology first. That's how I treat. Stéphane, would you like to say something?
Yeah.
Marco?
I agree on that. I mean, what is difficult is the fact that most of the studies that look at seizure recurrence after withdrawal of anti-seizure medication has been conducted in normal patients, and we don't have the data for the patients with autism spectrum disorder. That is what is very difficult, in fact. Then meaning that you can decrease the treatment and try to withdraw, but at some point you have to be aware that you can't predict what is the risk at the population level.
So I would like to thank our speakers for being here, for preparing these lectures. This group is very special. We have been together in Geneva discussing comorbidities, and I think that here we have 4 strong voices that advocate for comorbidities in epilepsy, and we have more voices in the ILAE. So I think it's just about time to have comorbidities incorporated more and more to the epilepsy syndromes. This is the main purpose of this webinar and this session. We do not wish that epilepsy of comorbidities empty forever. And this is what we intend to do in the future. I'm sure that the whole ILAE will agree with us. Would you like to say something? You are all chairs now.
I think we really have to incorporate comorbidity in our way to not only assess the patient, but also to define syndromes and manage it also in the management of the patients. I mean, we are probably have to better incorporate this non-seizure outcome with the seizures outcome in the definition of the syndromes.
Colin?
Yeah, no, I agree totally. I think these co-occurring conditions in epilepsies are so important in terms of quality of life, and they're a key aspect of the particular syndrome or the particular disease, and they're essential in terms of understanding the impact of the conditions.
Marco?
I think that adult neurologists need to improve in that sense. I think that probably pediatric neurologists have historically had a more holistic approach to their patients. I'm not sure, but for sure, adult neurologists need to improve. I think that many colleagues now are paying attention to comorbidities. They are recognizing the importance of treating patients and not just their seizures, but I think that we can improve even more, and I'm very grateful for this webinar because it's going to promote awareness in that sense. I hope that many adult neurologists have attended despite the pediatric label in the title.
Okay, so thank you all, and I'd like to thank the International League Against Epilepsy for giving a space and every time more for the Pediatric Commission and for this common effort between the Pediatric and Psychiatry Commission that work together. We have worked together in the past 6 or 7 years, and we'll complete 8 years in 2025. Colin is a chair in the task force that represents an alliance between our commissions, and we truly believe it's necessary to work together. And also in November, we'll have a new webinar from the Pediatric Commission about developmental and epileptic encephalopathies. Thank you very much for sharing your Saturday with us, and it was a pleasure to be here. Thank you.
Thank you all.
Bye-bye.
Have a nice day.
Bye.
Bye-bye.
Bye.